first case is a 7-month-old girl, 7 months when she presented to us. However, her mum, as I've said, always listen to mum, noted that she had concerns from the age of 4 months. She had a cousin of a similar age, and she wasn't developing as fast as that cousin, so there were concerns. And at 5 months, the child was really quite floppy. At 6 months, she was admitted to a local hospital with pneumonia and feeding problems. And on X-ray, there were changes on both sides of the chest, and it was felt that the pneumonia was because the child was having trouble swallowing and, in fact, had actually aspirated food or milk or stomach contents had gone into the lungs. The diagnosis was delayed slightly. Because of that, the lungs appeared to be full of milk, if you like. But when that cleared, X-ray showed an enlarged heart. And so, investigations were done. We saw the child. The child was significantly hypotonic, i.e. floppy, significantly floppy compared to what you'd expect of a child of a similar age. Echo or heart scan showed severe hypertrophic cardiomyopathy, so a grossly enlarged, swollen heart, which wasn't pumping as we would like it. And again, muscle enzymes, or simple blood tests looking at muscle inflammation, were elevated, as you would expect in infantile Pompe disease. We felt this child was completely unable to swallow safely, and the child was then obviously diagnosed with infantile Pompe disease by the standard enzyme test in blood cells, done by Alan, thank you. Right, Alan Cooper, not Alan Muir, I should say. Too many Allans, right. I'd like to apologise in part because it's difficult to see this, and in part because I haven't been able to get my video to work. This is the child's echo or heart scan. This is a cut through the heart muscle. And if I get my thing here, this is the left side of the heart that pumps blood around the body, and this is the muscle. This is the cavity in the middle of it, which should be full of blood, and this is the smaller right ventricle, which pumps blood to the lungs. This is the wall between the two, and that's sort of 4, 5, 6 times the size of what it should be. It's a grossly enlarged, swollen muscle. And if I was able to run the video, you would see that when the heart squeezes or contracts, the space here, which should be full of blood, completely closed. So actually, the heart was pumping all right, the muscle was contracting, but the problem we had was that the time to then fill the heart up with blood again before it squeezed again was so minimal, this child, despite the muscle appearing to work all right, actually had fluid in the lungs and was struggling. It was in heart failure, if you like. And so this was a real problem, and a very grossly enlarged heart, worse than we'd ever seen before in our previous infantile patients. And this is another picture of the same sort of thing. Right, so we were pretty worried about this child and wanted to start treatment as soon as possible. However, we had real concerns. This is a child who was in oxygen, who was very breathless, and his heart was struggling. And our cardiologists, our heart specialists, were saying, we're very worried about this child. Normally, we'd want to give this child diuretics, medicines to offload the heart, make you pee more, but they worried that if the child became dehydrated at all, then again the heart would fill with blood even less, and actually, you know, the output of blood from the heart would actually drop and the child could deteriorate. So we were left having to cope with the child who was breathless and had fluid on their lungs and not be able to do a huge amount about that. So we wanted to start with treatment as soon as possible. However, and I'll show you a graph on this in a minute, when this child arrived, our discussions at the time, and it was really our nurse specialist who had a better memory than any of us, thank you, Joan, reminded us that actually some of our patients took a little while to improve from the heart point of view. And in fact, when we looked back at this, and this I hope is where the registry will come into its own in the future, as we can only really go back over our last 5 patients, as they were the ones that we had so much data on. I'll try and explain this graph to you. Don't worry about the time not being completely linear, it's just to squeeze it all on the chart. This 0 here, this up here on this side is the function of the heart, okay? This is the change in function of the heart as you give enzyme, okay? So if the heart wasn't changing at all, it would start at 0 and go along with treatment, okay? So we would expect we give enzyme replacement therapy to a heart with infantile Pompe disease, we would just see a steady improvement. But what actually we saw in several patients, and I hope you can see this okay, in 3 out of the 5 patients, there was an initial deterioration in the function of the heart, and then a slow improval in the heart. So all the hearts responded, but some of them took a while. And we're actually looking for some of them to improve 3-4 months of treatment before those hearts got better. And in 1 or 2 cases, in about 3 out of 5 cases, they got significantly worse. And it'd be interesting to see registry data in the future as to whether this is replicated in other centres. This has been other people's experience. Our concern was this child's heart was so significantly impaired that if things were to get worse, then even though we think we can make this child significantly better, the child may become much more unwell. So our theory, again backed up really by very little in the way of science, was that rather than giving treatment every other week all of the time, for the first 12 weeks we would give treatment every week, and to try and avoid that deterioration in function. And then we would follow that, after that 12-week period with the standard every other week treatment. I think it's very important to say to you all at this point, this is not standard practice. This is us confronted by a pretty unwell child and discussing this plan with all of the consultant group in the UK who deal with infantile Pompe patients. So this is not standard practice, and I'll be told off by Jen a bit later on for doing this. But this was the way we felt we could, make sure this child did as well as possible. I think it's very important at this stage to say other treatments are very important. Not in place of Myozyme, but as well as. These children, when they are diagnosed, are generally very, very sick. They need to spend quite a bit of time in hospital. They are very precariously balanced between dehydration and heart failure. And significant infections could cause a real trouble and in fact be life-threatening. So the children do need other cardiac medications, diuretics in this child very, very carefully, and beta blockers, a very good old-fashioned drug used generally to treat high blood pressure, etc. One of the functions of beta blockers in this case would be to slow the heart, so the heart rate is slower, more time to fill up with blood. Don't ask me any further than that. I'm not a cardiologist. Okay.